Hi guys, welcome to my YouTube channel. This is Dr. Asmita and we're going to continue our chapter, like our topic cervical precancers. Yesterday we have done precancers के बारे में basic things like what is squamous columnar junction, what is a transformation zone, what is squamous metaplasia, what is CIN, what is LSIL, risk factors for CA cancer, HPV, things about the vaccines, and today we'll be doing screening. So I hope everybody knows what screening is for. We screen a general population for diseases for which they might not have developed the symptoms yet. Okay, so this is basically to catch the disease at a very preliminary stage and treat it before it becomes much worse and untreatable. So like I had told you yesterday that the time when the HPV or any risk factor causes any significant changes, or maybe cervical precancer, it's about 5 years. But from cervical precancer to invasive cancer, it's 20 years. So we are screening in this. We want to catch the disease in this period. Or if possible, since the disease time is 20 years, we want to catch it here very early on so that it doesn't become this and we can treat it earlier. So now screening methods, we have cytology, we have HPV DNA testing, and we have visual inspection with acetic acid. So the whole point is, first I'll tell you VIA, visual inspection. So you put a Cusco speculum in this, as you can see, this is the cervix. This whole, the pink thing is cervix, this is the os. So you can see already, you can visualize, visual inspection. So first you will visualize like normally, okay, so whether the cervix looks healthy or does not look healthy, and then you will put acetic acid here. Actually there are more steps which I'll tell later, but briefly you will put acetic acid and there will appear these whitish areas. Actually here, see here, when you put these whitish areas will appear, and if those changes are there, that means there is sorry, that's my phone. Yeah, so these changes will appear, and then you have to see whether cervix is healthy or not, and if you feel it's not, it's an unhealthy cervix, you can proceed as per to the protocol, which I will explain later. Okay, so cytology, then this is visual inspection with acetic acid. There was one visual inspection with Lagol's iodine, that other one also that we are not doing now is just acetic acid. Then we have HPV DNA testing. So what we do is we take a sample, and in those cells we try to see if those cells, like I told you, the HPV DNA incorporates itself in the human cell DNA. So we take these multiple cells and we test them whether they have the HPV DNA or not. Now there is a simple test which just tells us whether HPV is present or not. And then there is specific tests also which can tell, like high risk specific tests which can tell whether high risk HPV present or not. I hope you guys can tell me which are the high risk HPVs. You remember the class 1 carcinogens I had told you, 16, 18, 31, 33, 52, something blah blah blah, goes on. Even I don't know the list, but you get the point. The high risk ones are present. It doesn't tell which high risk one is present, but it will tell high risk present or not. Then there is HPV 16, 18 present or not. So this will tell whether HPV 16, 18 are present or not. So these are 3 types of HPV DNA tests which are available. Then coming to cytology. For cytology, we have 2 types. We have a smear based and we have liquid cytology. So you know our smear is your pap smear, Papaniculo smear. Now what we do is we take the airy spatula. I think my voice, hello. Sorry, I don't know why I said hello. Yeah, we take the airy spatula, we twist it at the endocervix, the longer end on the endocervix and the ectocervix, and then first we either put it on a smear or we dip in a test tube containing some fluid. Now when we put it on smear, this is smear based, and so what happens on smear is, what will this wooden airy spatula will do is, the cells which have been shed, it will collect those on its tip, and when you put it on the smear, what happens is those cells, the shedded epithelial cells, will come on the smear, and then you can study this under the microscope. Now what happens is, when you study this under the microscope, so now what happens is, and if you put it in the liquid, all the cells will come inside the liquid, and then you can centrifuge it and then study. So that is one smear base. And liquid base also you do the same thing. So what are the advantages and disadvantages? I'll just tell you briefly. When you put it on the smear, sometimes all the epithelial cells might not get transferred, and if there is bleeding, if there is any other discharge, you might get other cells also. So we don't do pap smear if there is bleeding, because it becomes difficult to interpret that test. You might get an unsatisfactory cytology report. But whereas on liquid, when you are centrifuging, everything will separate. So presence of blood or absence of blood is not a problem. So that is your cytology. So you have liquid based and smear based cytology. Now coming to the next part. So now the method that we use, that I have described to you all, like this is what your reporting is done based on the Bethesda system. Okay. Now first I'll tell you what age should we start screening. Now different guidelines say different things, but what we do is, if we are doing cytology based screening, you can start from 21 years. Okay, preferable 21 years, because not before 21 years, because the amount, see, first of all, the in India especially, the onset of sexual activity, the marital age is only 18, right? And by 18 to we assume that they are getting sexually active from 18, and it takes around 3 years for any HPV virus or any something to show any significant changes. So 19, 20, 21. So that is what we are assuming here. And irrespective also, if there is earlier onset of sexual activity, irrespective of the marital status, then also the amount of people that you will screen will increase, first of all. Second, HPV infection, if you remember, it clears off. It clears. So you might not get actually any changes. So 21, the risk versus benefit, like the cost of doing the test and the benefit that you're deriving out of it is actually better from 21. And then you have to do it every 3 years, and you can stop at 65 years. Now, this is the one thing. Second, if you're doing HPV DNA testing, then you start only from 30 years. Like I had said, if she's acquiring the HPV infection by 21 or something, she'll be 26 if she is acquiring. And for any significant changes to appear, it will again take 5 years. So we take it only 30 years. Before 30 years, we assume that it will get cleared off. Now, also, and you have to, if HIV negative, you can do every 5 to 10 years. For remembrance sake, I remember 5 years. You can repeat it every 5 years, and you can again stop at 65 years. Now, if you're doing visual inspection with acetic acid, you can again begin at 30 years. You have to repeat every 3 years, and you can stop at 50 years. Now you'll ask, here you are stopping at 65 years. Here you are stopping at 50 years. Why? So, what happens at 50 years? Most women achieve menopause at this time. Okay, menopause. And if you remember the transformation zone, first of all, we take the visual inspection, we need to visualize the transformation zone. And if you remember, I had told transformation zone is dynamic, hormone dependent. So when like I had described here only, this diagram mein, this. So if estrogen is more, the transformation zone will move out, and if it is less, it will go inside. It will go inside. It will disappear. So visually, if you cannot visualize the transformation zone where the HPV is epitheliotropic, where it tends to infect, and that zone itself has gone inside, what will you see? So we stop VIA at 50 years, and we can cut. So does that mean that we stop screening altogether? No. Then we switch the mode of screening. Now you are asking, what if a woman comes at 65 years, comes at 65, and no previous screening? So what you will do is, you can screen her, and then you can stop at 75 years. It will be a decade. You can, if you are doing a 3-yearly screening, or like with HPV 5, you would have done it 2 times. So basically, a woman must be screened for it at least 2 times. And now after 75 years, even if you detect a precancerous lesion, for it to progress to invasive cancer, it will again take 20 years. No point. And if at 75 years you're not detecting anything, unlikely that you will have a CA cervix progression. So if she's coming at 65 years and there's no previous screening, you can screen and you can then stop at 75 years. Okay. Now you will say ki, okay, she's okay, yeah, that's all. Then what does a positive test mean and what does a negative test mean? If a woman has a positive smear, positive cytology or positive HPV DNA or any positive, like if you get results on visual inspection, what does that mean? So first of all, visual inspection, so the whole protocol is different. I'll just tell you about cytology and HPV DNA testing. Cytology is more sensitive. What does that mean? That it is more likely to pick the people, like it is more likely to pick up the disease. If 100 women are getting screened, it is likely that it will detect around 96. Okay. Now this actually they have done this test in which if you are doing yearly, it picks up around 98 or 99, and if you do a 3 yearly pap smear, it detects around 96-97% people, and if you do a 5 year, it detects around I think 70 to 80%, something like that. The whole point is 1 year pe you are detecting this and 3 pe this. The difference is almost 1 to 2%. And see, the number of people would decrease like that. So it's better to do it 3 years. Like if somebody requests, you can do it yearly also. But this is what government and this is what all the guidelines recommend, because it decreases the burden of the disease. Okay. So it is more sensitive. So it is more likely to pick the people who might have a precancerous lesion. Okay. But is it specific? Everybody who tests positive, disease, yes or no? This is no. Everybody who has tested positive does not mean will have the disease also. You understand? So it's not a specific. So that means you cannot treat based on cytology. It's a screening test. You need to do a diagnostic / confirmation test. Confirmation is actually biopsy only. So that's why you will see later on that most guidelines converge to colposcopic associated biopsy. So that's why with cytology, since it's a more sensitive test than a specific test, you require to do, so you cannot treat directly. Like everything in medicine, there are exceptions to this also, which I will tell you later. So that means this. So I hope you have understood this. Whereas the HPV DNA testing is there, it is more likely that if you're testing from it, yeah. So it's a, sorry. Now it is also a good sensitive test. Okay. Sorry, I had to check the fact. Okay. Now moving on. Okay, like I just told you, HIV negative 5 yearsly you repeat, and HIV positive you have to do it 3 to 5 years. It's in setting like India, I think it's better to go with 3 years. But okay. So now this I have told you the basics. So now how do you report? So what you are seeing in cytology, you have to give it a language, because this is a pathologist who's going to read the report. And what will a clinician interpret? What a pathologist seeing, the clinician also has to interpret. So this is the Bethesda 2014 is the latest one, 2014 Bethesda system. So first it will tell you like how a report comes. It will tell you whether it is a PAP, like what specimen type, whether it's a PAP, liquid based, like I had told you, we are doing liquid based cytology, which we do an endocervical, that not endocervical, we use a cyto brush, and then with that we use, actually I forgot what that brush is called, but you get the point. Then whether the specimen is adequate or not, this is very important. You cannot, see, it's such an important test. A person anyway is going to get screened. once in 3 years or once in 5 years. So the specimen should be adequate. So satisfactory for evaluation means that first you have to tell whether there is presence or absence of endocervical transformation zone component. Why is transformation zone? See, if transformation zone is not present, transformation zone is the zone where the HPV infects more than the squamous region and the columnar region. So you definitely have the transformation zone component definitely has to be there. If it is not there, it is not directly actually called an unsatisfactory smear, but it's close to unsatisfactory, because anyway you'll have to then repeat the smear in 2 to 4 months. Then other, like if it's obscuring, if it's not been taken properly, if there is any blood, any inflammation, any cervicitis, any inflammatory cells are there or not. And unsatisfactory, then you have to tell why unsatisfactory. Okay, so unsatisfactory could be like inadequate cells, not fixed properly, you cannot, there are no other cells visualized, or like that, if there is extra blood present. Now general categorization, first that the report that it comes as negative for intraepithelial lesion or malignancy. This is what the report comes as. Okay, now second is endometrial cells in a woman aged more than 45. This is also okay. Then third is epithelial cell abnormalities can be there. Now if it is coming as NILM, that means there is no cellular evidence of neoplasia. Okay, that means when you were examining those cells appeared normal. There was no nuclear, the size was not increased. Okay, there were multiple nucleolus was not there. All those things that we had read in the pathology neoplasia chapter in abnormal dysplastic cell are not there. So that means no cellular evidence of neoplasia. Okay, now what are then you have non-neoplastic findings, and then you have epithelial cell abnormalities. Non-neoplastic sign can be non-neoplastic cellular variation. Squamous metaplasia, I had told you, squamous metaplasia is a normal change which happens. So getting it, like as a pathologist, one should not get scared. Oh, what are these changes? No, it's normal, it's bound to happen. Then keratotic changes. I'll use a highlighter only. Different shade will take. Squamous metaplasia, keratotic changes. Keratotic means technically hardening. Okay, the cells are stiff. Actually, I'm not sure exact definition. I'll find out and let you guys know in the description. Tubal metaplasia, atrophic changes. If you're taking it 45 years, 50 years, you can get atrophic changes, pregnancy associated changes. Okay, so these are the things. Then what are the reactive cellular changes? You can get lymphocytic any IUCD, any radiation induced changes, and you can get glandular cells post hysterectomy. Okay, sometimes what happens is when you remove the uterus, some glandular cells, because see, then there are from the uterus secretions come, from the vagina cervix secretions come. So sometimes glandular cell hypertrophy can occur post hysterectomy. This is normal. So that is non-neoplastic findings. Then what infection? It can actually be a good question. What infections can you detect by pap smear? I know Candida is the first thing that comes to everybody's mind, but Trichomonas is actually one thing that we should remember. Trichomonas vaginalis. I'm covering it with green because you might have greenish discharge. Okay, you can get bacterial vaginosis, Candida, actinomyces, you can get herpes and cytomegalovirus. So which 3 virus can you get? Don't say HPV. You cannot tell HPV. You can just tell the HPV associated changes are there or not. So it can tell herpes simplex virus, cellular changes consistent with cytomegalovirus. Bacteria, you can get Trichomonas. Actually, Candida is all fungus only. Sorry. Bacterial vaginosis bacteria you can get, or you can get, fungal is your Candida. Then you can get Trichomonas vaginalis, bacterial vaginosis, actinomyces species. Okay. Now, next you can get endometrial cells also in a woman aged more than 45 years, which is fine. Epithelial cell abnormalities. Now you have squamous cell, you have glandular cells. Okay. guys, it may appear that a few of my concepts also not, I have certain doubts. I will clear them off and let you guys know in the description section. So please feel free to come back to the description of this video and see. And if you guys feel that you know more, you can let me know. Like, I'm not sure about this endometrial cells in a woman age more than 45 years. This I have to read. Okay, now epithelial cell abnormalities. Squamous cells are there and glandular. When you get, so you know there are squamous cells are there and columnar cells. Now between these columnar cells there are glands also. One thing I had not told you is when squamous metaplasia happens, these glands can get blocked and fluid can accumulate here. So these are called Nabothian cysts. These Nabothian cysts, when you get or when you see, they appear a little whitish. So you have to differentiate them from acetowhite areas and others. Okay, so like basically white area, when you're checking, you have to see on cervix, you have to see for Nabothian cyst, you have to see for leukoplakia, and you have to see for acetowhite areas. These will be like regular whitish areas. Leukoplakia is without application of acetic acid, and acetowhite with acetic acid. Okay, then you get atypical squamous cells. You get atypical squamous cell, undetermined significance, or one cannot exclude HSIL. Then you get LSIL. Then you get high grade HSIL, which is equivalent to CIN on biopsy. When you get HSIL, you can expect that when you do biopsy, you're likely going to get CIN1. But if you're getting CIN1, does that mean it will always be HSIL? No. Understood? It's not the other way around. HSIL corresponds to CIN1, but it is not always the other way around. Then you can get CIN1, LSIL, and CIN2 and 3 will be HSIL. So CIN1, when you're getting LSIL, that means you can get CIN1. But if you're getting CIN1, that does not mean that you will always get LSIL. Likewise for HSIL, if you're getting HSIL, you can say that CIN2 or 3 can come up on biopsy. But if you're getting CIN2 and 3 and you want to know what was cytology, it does not have to be like it will always be HSIL. It can be different also. But that's why CIN2 and 3 definitely you have to treat. This you can observe. How much to observe, till when can you observe, that I will tell in the next video. Okay, then if you're getting glandular cell, you will get atypical cells, which can be endocervical cells, not specified, glandular cells, not specified. Sorry. Atypical cells, you can say which favor neoplasia, glandular cells which favor neoplasia, endocervical adenocarcinoma in situ, or you can get adenocarcinoma. So these are the findings for squamous cells and glandular cells. Now if you're getting, you have to specify there. Okay, so this is your reporting system, Bethesda. I hope you guys have understood this. Now what the American guidelines say is, for women aged 21 to 29 years, you can screen with cytology alone. This is a grade A recommendation. That means that they definitely recommend it. Okay, so 21 to 20, like I said, you can do 3 years cytology. Every 3 years you can repeat. For 30 to 65 years, you can either do every 3 years with cytology, every 5 years with high risk HPV testing, or every 5 years with core testing. What is a core test? Core test just means two things together. So you do cytology, the pap smear or liquid based cytology, plus you do HPV DNA testing. And if you're doing both these together, you can do it every 5 years. It is also a grade A recommendation. And women younger than 21 years and older than 65 years do not screen for cervical cancer, grade T. That means it is definitely not recommended to screen women under less than 21 years and older than 65 years. So I hope you guys understood this. This is the same thing again. Now older than 65 years, against the United States Preventive Task Force, recommends against screening for cervical cancer in women older than 65 years who have had adequate prior screening. What does that mean? What is the meaning of adequate? That they have been screened every 3 years for a lifetime, or have they been screened for the past 5 years? No, it means past decade, past 10 years, screen negative. So if they were getting every 3 yearly PAP, last 3 PAP negative, done at an interval of 3 years. And if you're getting HPV DNA, then you are doing it in 5 years. So 2 times it has come negative in the past decade, then you will stop screening and these women will come out of the cycle. Okay. Now the WHO and even Foxy, see, basically some countries have a very good screening system, like America, the first world countries, Netherlands, and all these some European countries, they have Australia, they have a very good screening system in place, and their population is also not that much, so they have good resources, so they can do tests which we as a developing nation might not be able to do. So American guidelines, I understand that they are for people who can do everything perfectly, but in a setting like India, that may not happen, and especially other developing countries or third world nations, that is not possible. So WHO comes up with guidelines to tell these countries what they can adapt based on their existing medical infrastructure. Also, Foxy is the Federation of Obstetricians and Gynecologists in India, and it modifies those guidelines according to, as per India's needs. So they have divided into good resource setting and limited resource. In limited resource setting, they are saying you do VIA and you do HPV. So I'll tell you why. When you're doing VIA, you yourself can tell the result. Whatever you're getting after it, you are able to analyze it and interpret it. Same in HPV, you will get a positive or negative, you'll do a test and you'll get a positive or negative result. You know how those malaria kits come? It's like that. But if you're doing a cytology, first you need a proper infrastructure where people can take these smears for everybody. Then they will go to a pathologist. That pathologist has to report it. Then that has to be reported and then come back to you. So there is one additional person and more infrastructure required for cytology. So in limited resource setting, VIA and HPV can be done. So in India, what are we doing? Mostly we are doing VIA only, because the HPV tests available in India are not standardized yet. Once I feel we get a standardized test, it will actually be better to do HPV test. Also, this is not a blood test. It's also, you take a, because like I had told, there is no viremia with HPV. So what you do is, that smear that you are taking and putting on the slide from that spatula, you dip it into the fluid and cells will be there. This kit will test this fluid and tells HPV positive or not. So this is also one advantage for a liquid based cytology. With smear test, you cannot do HPV testing, but with cytology you can. You understood? If your cytology means you're doing a smear or you're doing liquid based, but on that glass slide you cannot test for presence of HPV DNA. But if you have the liquid available, with that you can test the type of lesion also, and you can also test HPV DNA present or absent. I hope I have made sense. So that is what I'm saying. So low resource setting mein the test is VIA or HPV. In India, we are doing VIA more because HPV tests are not standardized yet. Then this is screening tool. In a good resource setting, you can do a HPV test, you can do a co-test, HPV plus cytology, or you can do cytology, or you can do VIA. So what we are doing is, at Kasturba Hospital, we are doing cytology. Now, what are the triage tools available? Triage means, okay, you have done screening. Now the screening tool has come positive. So 2 things you can do. In very low resource settings, you can do see and treat approach. This is actually not low resource, it's a single visit. Imagine a patient is coming to you and they're saying, we don't want to come back for another test. What ideally should be done is, you screen patient comes negative, you do routine follow-up. You screen, patient comes positive, ideally you should do another test, because in life all of us can be right or and wrong, and if we are right we should double check, and if we are wrong we're also, well, we are double checking. So another, if it's coming positive and you want to do another test and that comes positive, then you will treat. But sometimes direct treatment can be done. If a patient you fear that might be lost to follow up, so then you can do the single visit approach and you can do see and treat. Okay. Second, there is a screen, see and treat approach. So you are screening, another test you are seeing, and then you are treating. So this is actually for people who are ready for follow-up. You can do this also, depending on the type of lesion, type of results that you are getting, all of that. Now, like I said, for screening, these 3 tests and these 2 in limited resource setting. In triage, we have, for triaging, you can do HPV test, you can do HPV genotyping. This is that test, this is the same test, but it can tell you 16-18% or not. You have to do biopsy. Okay, biopsy from abnormal area, not from any other area. The area that you think is abnormal, you take biopsy from there. So that you will have a tissue diagnosis. You will now with cytology and all of this, so you just know HPV present or absent, LSIL, HSIL. But with biopsy, you will have a diagnosis of CIN1, CIN2, CIN3, or at least you'll be able to rule out invasive cancer. Okay. Or you can do co-testing also. And in limited resource setting, you directly do colposcopy. If available, biopsy. Okay. Colposcopy is nothing, it's just magnification. You're just magnifying the cervix. Imagine taking a magnifying glass and seeing the cervix. It's like that only. You are better able to differentiate if the transformation zone is type 1, type 2, type 3, whether it's fully out or not, if there are any abnormal vessels or not, like that. So that you can do. Because in low resource setting, you've already done this. There's no point of doing these again. Anyway, genotyping will not be present. So you do colposcopy, and if biopsy facility is there, you send a biopsy. Okay. And anyway, in limited resource setting, we are actually going with screen and treat only. So it makes sense. You do VIA this, and then you directly come and treat. So for treatment, you have ablative procedures and you have excisional procedures. So ablation mein you have cryotherapy, you liquid nitrogen ka gas comes and we put it on cervix and it like denatures everything and destroys those cells. You have thermal coagulation and you have CO2 laser, you have all of that. And for excisional procedure, you have LEAP and you have conization. Loop excision, loop excision procedures, loop electrosurgical excision procedures. Okay, so you have LEAP. Excuse me. Sorry. I had to switch off the AC. So you have LEAP, cryotherapy, you have thermal coagulation, you have another excisional procedure which is called excuse me, cryotherapy. I'm not going to edit my sneezes out. Cryotherapy and thermal coagulation. Now these are the tools, screening tools, triage tools and management options. These management options are for if you're getting like low grade lesions. You have to understand this. With these tests, unlikely that you will get a invasive cancer. Why? Because a patient with invasive cancer will come with symptoms. Post-coital bleeding, post-menopausal bleeding, such symptoms will be there. Post-menopausal bleeding is actually endometrial carcinoma before cervical cancer, but what I'm trying to tell you is if the cancer has invaded, the patient is going to come with symptoms. Here we are screening for patients who are young, who are symptom-free, and who might develop an invasive or symptomatic disease later. And hence you are able to treat also. That's why you don't have to necessarily do a biopsy and confirm. Because most scenarios, you are more likely to get a invasive, like you're more likely that the patient will not have an invasive cancer. Okay. Now, according to this, you have a good resource setting. You have HPV, cytology, VIA. You're doing the screening from 25 to 65 years. Limited में we have VIA. We are doing 30 to 65. In postmenopausal women, screening with VIA may not be as effective. Why? that you guys remember, because the transformation zone goes in where? In the endocervical canal. It moves inside. Okay, now age to start, you start cytology at 25, and HPV or co-testing you can start at 30 also. VIA also you start at 30. Frequency, if you're doing co-testing every 5 years, cytology every 3 years, and VIA you're doing every 5 years, at least 1 to 3 times in a lifetime. Okay, when do you stop? In a good resource setting, you stop at 65, consistent negative results in the last 15 years or even a decade. With no prior screening, should undergo test once at 65 years. This is very important. So once at 65 years, and if negative, they can exit screening. Okay. Then follow up, you have to do. See, now if they had imagined you had done cytology, they got LSIL, and you had done a co-testing and HPV DNA was there and it was positive. So you will do a treatment, and it was fulfilling the criteria for cryotherapy, which I will tell you later what it is. So you did cryotherapy. So basically this approach, screen, test, treat, or screen, treat, you then, and you have treated it. So how do you follow up that person now? Because see, that was a pre-invasive, you have treated without maybe biopsy or with biopsy, but you need to know that patient does not get infected by another HPV, high risk HPV. That is possible, right? Because it's sexually transmitted. It doesn't mean that you have treated, the patient will not get a repeated infection again. So you will do HPV testing preferred or cytology every 12 months, VIA 12 months. Now if you are getting abnormal reports, CIN2+, irrespective of method of treatment, you have to do 20 years. Okay. Then screening, now women who have had a hysterectomy. So following hysterectomy, if there is cervix was removed, so there is any benign cause, like fibroids were there or something like that, if the hysterectomy was done, then there is no need for screening. Okay, unless there is history of previous CIN. Okay, for CIN we never do hysterectomy. Okay, we never do hysterectomy. So we would, so if a woman have had hysterectomy, cervix was removed for some benign cause, there is no need for screening unless there is history of CIN. Second, absence of cervix you have to confirm. Okay, and if indication for hysterectomy is not clear, then at clinician's discretion you can do. In women with hysterectomy was done and CIN comes, because that uterus you would send for HPE, right? And in that maybe CIN came. So you have to do HPV DNA at 6 months and 18 months, and if negative you can stop. In immunocompromised women, you start within 1 year of onset of sexual activity. You can do any of these, and you have to do every 2 to 3 years. If VIA or if afford, actually HPV testing is preferable, and it's written every 3 years, but you try to do twice as often as general population. So if you're calling somebody every 3 years, you can maybe call them at around 2 to 3 years interval, you can call them. Now, okay, we have screened. Now what? So I wanted to do this management protocol video now only, but I feel it is better that we do it later, because I think I've given you guys a lot to follow and read up. So I think maybe you all can go through all of this together, and we've had some doubts, we can discuss them before starting the next video. So today what we have done is, what are the questions that you can revise now, think about is screening tools, when to do, how to do, how often to do, when to stop, and basically resources, in which resource setting you will do what to do in HIV positive people or actually immunocompromised status, what to do in women with hysterectomy, also Bethesda system of reporting, and yeah. So I hope you had fun. I hope it wasn't confusing. May have been a little long, but I think this topic requires some attention. So Thank you for joining today. I hope you enjoy. I'll see you later in the management of cervical precancers. Thank you so much. Have a great day.